Okay, hello everyone. Good morning. I'm Dr. Farwa Aslam and I'm your host for today. I hope I'm audible to everyone. If yes, please, just write some yes in the chat. Can everyone hear me? Okay, perfect. Perfect. So I have a lot of yeses here. So thank you so much. Thank you so much for giving your time and joining this webinar. I hope I don't put you to sleep while I'm talking. So let's just wait for 2 minutes for everyone else to join as well. Till then, there are some points for all the audience here. Please keep your cameras and microphones turned off. Uh, Type in any questions, whatever, while I'm talking, there might be a question that pops up in your head. So don't wait till the end of the webinar because, by the end of the webinar, you might just forget about the question. Just write it in the chat box. I will answer it at the end of the webinar. Okay. Okay, so I hope everyone has joined us today. The topics that I'm going to cover is role of communication in interpersonal skills. We are going to talk about some refusal stations, some breaking bad news stations, and how to make the best use of your 8 minutes. So I'll start with the interpersonal skills. To be honest, I'm not going to talk a lot about interpersonal skills, although maybe a lot of people today here are here for the interpersonal skills. In PLAB 2, there's a lot of emphasis on interpersonal skills, communication, act nice, be the nice doctor and everything. But I personally think that there is not a lot to talk about. Why? Because, I don't think that as a doctor, you were not taught to act as good doctors in medical school. You were taught to be good doctors. So my advice to you is just be yourself, be kind, be the good doctor that you already are. You don't need to learn the interpersonal skills or communication. You already know that. You already know how to talk to a patient, how to listen to a patient, how to help that patient. Each and every one of you have encountered some patient at some point of your life, maybe during the med school, during your clinical rotations, maybe during your internship, house job, during your job. Maybe you are just sitting home preparing for the exam, doing nothing, doing some non-clinical job. Even in that case, you must have interacted with some patients. That could be your relative, someone at your home, and your relatives and your neighbor. So you know how to listen to a patient and how to find a solution for that patient. That's all you have to do in PLAB 2. The best advice that I can give you today for PLAB 2, for interpersonal skills, is that when you enter the GMC building and you have to go into 18 different cubicles, and obviously you are nervous, just think of these to be 18 patients that you are going to see today. Yes, I am. 1 minute. Okay, Asher, are you able to hear me? Okay, perfect. So I was just saying that in interpersonal skills, the most important thing is don't try to act. Trust me, don't try to act. I've seen doctors who are who are like they are trying to be they're trying to act very nice. Like, oh my God. Okay, I'm very sorry. No, don't do that. Just be yourself. Be nice to the patient like you are in your daily routine. Try not to act because all your focus will be then on acting to be a nice doctor rather than focusing on the station. Okay, so those 18 stations should be like your 18 patients that you are going in to see in your hospital today during your ward round, or these are just 18 different beds in your hospital. Okay, the next thing, I think interpersonal skills, the most important thing is active listening. What is active listening? Okay, active listening is not only just listening to the patient while okay, sure. Okay, good. You can hear me now. Okay, so what is active listening? Active listening is not something like if I'm talking and you're just listening to me, like I'm talking right now, and you're not able to see me. So just imagine that you're in the cubicle, you are listening to the patient, but you're not even looking at her, at the patient. You are not seeing at the patient right now. You're not able to see me. Okay, I'm just here talking, but I'm nervous. I'm doing a webinar, I'm talking to a lot of people, I am nervous. I'm doing a lot of hand gestures, or I might be, I might have social anxiety, I might be sweating, I might be having a panic attack, I might be having palpitations, or I might be biting my nails, or a lot of other things, okay, while I'm talking to you, but you didn't notice because you are not actively looking at me. You are only concerned, okay, when you enter the station and you have this a couple of questions, you all have these strategies, these approaches, these questions, a list of questions for all kinds of stations, okay. When I started to prepare for PLAB 2, let me quote my personal experience. What I was doing is I had these questions in my head while when I was practicing the station. I was like, okay, now the patient is talking about the presenting complaint. The next thing I need to ask is the history of presenting complaint. Okay, so now when the patient was talking about the history of presenting complaint, in my head, I was on the next step. Okay, now I have to ask about DESA. Okay, I'll be asking about exercise, smoking, blah, blah. While the patient was talking about those things, in my head, I was on the next step. Okay, the next thing I will be asking this. No, don't do that. Just listen to the patient. When actively listening means listen to anything the patient says, the patient does. It could be verbal cues, it could be hand gestures, it could be body language, it could be any expressions on his face, it could be any particular, any twitching of his hands, anything that he is doing. When you enter the cubicle, all you have to do is acknowledge every single thing that is happening in that cubicle. Every little thing you have to acknowledge, okay? Not only just what he's saying, but what he's doing. When I say acknowledge, like, sometimes maybe you enter the cubicle and the patient is holding his head, okay? Or maybe the patient is looking at the floor. He's not looking at you. Or maybe the patient is just walking here and there rapidly, and I don't know, he's just walking here and there. Anything, any of these things, or something else the patient is doing. But what you do is you read the scenario, you enter the station, you are like, okay, hello, I'm Dr. Farwaslam. Good morning. Can you please confirm your name and age? How can I help you today? Before even doing this, you need to acknowledge, you sense the tone of that room. Okay, the patient is holding his head. He might be upset. He might be depressed. He might be in pain. Ask him, okay, the first thing that you have to do is acknowledge what he is doing. If he's sitting quietly, that's fine. That's very cool. But if he's doing one of other things, you need to acknowledge that before even starting the station or before talking to the patient. Okay, ask him, okay, you seem upset or you seem depressed, or are you in pain? Can I help you with that? Okay, and then you go with, okay, how can I help you today, or whatever your presenting complaint is. Okay. Another thing about active listening is always follow your patient. Trust me when I say this, the patient in the station, in that cubicle, is there to help you pass. Trust me, he is there to pass you, and please let him help you to pass that station. That patient is going to take you to the end point and give that green flag to you that, okay, you passed the station. But all you have to do is follow the patient. Don't rush him, don't push him with all the questions. Just let him talk. Trust me, he is there to talk. He loves to talk. You need to listen to the patient. You need to make him talk. All these questions that we give you, everyone, you'll have lots of notes, so many approaches, so many questions. All those questions are just like trust me, they're not there for you to ask them. They are there like it's like a last resort, last bullet in your gun, maybe. That if, for example, the patient has talked about everything, okay, and now you still think, okay, I haven't reached the diagnosis, or maybe I'm missing something, or you have no clue, you are still sitting clueless, okay, then those are your savior questions, and then you can ask those questions like, okay, do you have this, do you have that, or not. But first thing that you have to do is you have to let the patient talk. Please let the patient talk. Trust me, sometimes even in one sentence, the patient will tell you everything, starting from, okay, I had pain in my stomach, and then I had stones in my gallbladder, I had my gallbladder removed, blah, 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 everything just in 2 minutes, in first 2 minutes. You are done with all the data gathering in first 2 minutes sometimes, but you don't actively listen to the patient. And then what happens is you are wasting your time by repeating the same questions again. Okay, have you had any surgery in the past? Oh, he already told you he had a surgery in the past, but you didn't listen. You can ask, other than surgery you told me about, did you have any other surgeries? This shows, okay, you actively listen to the patient. So all you need to do when you enter the cubicle is be yourself, be the regular doctor in your clinic, in your hospital, and just listen to the patient and follow the patient. Okay, all the approaches, all the questions, all the whatever that's in your head, okay, for a particular station, okay, you are going to use it, but you should know how to use it. You know, there are almost 300 something stations in PLAB 2. They are divided into multiple categories. There is medicine, there's counseling, medicine counseling, psychology, breaking bad news, so many of them. There are a lot of different categories. And as a newbie, you must be thinking that, okay, when I go for PLAB 2, there'll be a station that, okay, the patient is here. The patient is being discharged. He came with DVT and he had a clot, and now we are discharging him on warfarin. But he's refusing to take the medicine. Talk to the patient. No, the station is never going to be like that. The station will be something like, okay, we are discharging the patient, talk about the medication, and you'll be thinking, okay, this is medication counseling. This is so easy. I'm going to go in and talk all about warfarin, the risk factors, the side effects, blah blah blah, and you'll be able to ace the station. But no, that is not going to happen. When you'll go inside the station and you'll get to know, oh my God, there are so many things. Maybe the patient, I don't know, maybe the patient is angry. You enter the cubicle and the patient is angry about the way he has been treated in the hospital. Okay, or maybe, and then maybe you came to know the patient is refusing something, any of these things. So what you need to be is to actively react on whatever the patient does in the cubicle, and then interlinking all those approaches and all those things that you have in your head, actively interlink all those approaches. Okay. So like we are talking about these approaches, I'm going to talk about refusal stations or refusal approach today. So again, like I said, refusal is not going to be a station. It is just going to be a part of that station. Okay. Can I have if anyone please can volunteer here? Anyone? And don't be shy. You don't have to be a good doctor. Just be as bad as you can. Obviously, if you'll be bad, then I'll be able to help you here. If you're already too good, trust me, I'll be confused on what to teach. Okay, Asher. So Asher, your scenario is that the patient, okay, let me think. Okay, the patient collapsed, had a history of fall, and the ambulance brought him to the hospital. His glucose levels are 2. Talk to the patient. Okay, now you enter the cubicle. Talk to me. I'm the patient.
Hello.
Hello.
I am Dr. Faiza Siddiqui, one of the doctors in the emergency department. May I know your name and date of birth, please?
No, doctor, I don't want to talk to you. I just want to go home.
Oh, okay. Okay. So I can help you if you have any issues. Kindly tell me.
I just want to go home. Doctor, I said, I just don't want to talk to you. I just want to go home. I don't know why they brought me to the hospital. I want to go home. Please, I want to go home, doctor.
Okay. All right. I can see you are upset about something, but I really need to know your name.
No, I'm not upset. I just want to go from here. Please, I want to go home, doctor. I want to go home.
Okay, all right. I will send you home, but if you really want to go home, we can do something about it. But first, you have to tell me your name and your date of birth, please, so that I can look into your notes.
Okay. Thank you, Asher. Thank you so much. Okay, so now here you can see is that you entered the station, you saw the scenario, and maybe you thought it's about fall, it's a fall station, or maybe it's a station about hypoglycemia. Okay, now I'm going to enter and I'm going to ask all about the, all the differential diagnosis of fall or hypoglycemia, and going to tell him, advise him, and give him this management and all these things. You get 1 minute to think about all these things, and trust me, you are going to think about all the useless things in the world in those one minute, and nothing is going to help you in the station unless you just be active and react actively to what's happening in the cubicle. So now I started with the patient is completely refusing straight away. He is refusing. He's not even going to talk to you. So the first thing, how to approach this patient. Okay. The patient is completely, he is not even ready to talk to you. Okay, so now what you are going to do? Now you have an approach for refusal station, or if a patient is refusing anything, it could be anything, it could be a medicine. This station I started with, I don't want to stay in the hospital. It could be a refusal of taking medicine, maybe being admitted to the hospital, getting operated about something, and he's refusing the operation, the treatment, anything. He's refusing anything. So there are some steps that you are going to follow. Okay. So the first step is you ask why. Okay. But before asking why, even before asking why, you have to reassure the patient. Don't offend the patient. You're not like, okay, no, but please first tell me what happened. Please tell me, how can I help you? Oh, no, please first tell me, why are you upset? No, just tell him. If he's saying, I don't want to take the medicine, sure, no problem. We won't give you anything against your will. I don't want to stay in the hospital. Sure, we are not going to keep you in the hospital. I don't want to be operated. Sure, we are not going to operate you if you don't want to. Anything, just say anything, but first reassure the patient that, okay, fine, we are definitely going to do whatever you are saying, we are going to do that. So reassure the patient, don't offend the patient, don't tell, okay, no, but please, first can you talk to me? No. Tell him, we are going to do whatever you are saying. Don't offend the patient, and then patient will be like, okay, now he's calmed down. Okay, now I know you have gained the trust of the patient that, okay, fine, they are going to listen to me, they are going to send me home, they are not going to give me this medication. Okay, fine. That is the first step. Now, this is just a step where you convince the patient to just sit there for, like, I don't know, 5 minutes, 2 minutes to talk to you. Now, how you have to convince the patient to take that particular treatment or follow that order, whatever you are asking him to do. Now comes those steps. Okay. So after reassuring the patient, you ask him, okay, but please can you tell me why you want to go, why you don't want to stay in the hospital, or why you don't want to take this medication, or why you don't want to get operated, whatever he or she is refusing. Okay. Now, what is this? This is the main concern. Okay. The eyes, the concern, you get the concern out of here. Okay. You don't ask what's your main concern. Okay. You just, please tell me why. Sure, we are going to do whatever you are saying, but please tell me why. Okay. So that why is the patient's concern. And now what you are going to do next? The patient told you, I have kids at home. I have a sick mother at home, and I was taking this medication to her, and so I need to rush back to a home, or whatever reason in the world he or she tells you. That is the patient's main concern. So now your focus is that main concern, and you have to be a good doctor, be the superhero or superwoman, superman, and find a solution to that particular concern. Okay, so you are going to find a solution to that problem. You are going to address that concern. Okay, when you are addressing the concern, always start with the easiest possible solution, the cheapest, the free of cost solution. Okay, and like, for example, if the patient is saying in this scenario that, okay, I have kids at home, I have someone to look after, I have to go home, whatever. Start with, do you have anyone else at home? Maybe you have any neighbors, any relatives that you can call and look for those kids, or for your mother while you are in the hospital, and we can treat you. Okay, the patient still says, okay, no, I don't have anyone, I don't have any help or anything. Then you go for something like, okay, we can help you with social services. We can help you with your kids or with your mother or whatever, but always start with the easiest solution. Okay, the most easiest, the most feasible solution, and then go towards, okay, not this, not that. Okay, you gave him all the solutions. The patient is still refusing. He's still saying, okay, no, doctor, no, I still want to go. I don't trust on anyone, or I don't trust the social services. I need to go home myself. Okay, so now what you are going to do next? You are going to check the mental capacity of the patient, because obviously you are sending the patient home against the medical advice. You need to check the mental capacity. Only in you can keep the patient in the hospital forcefully, or you can ask the patient to take some medication or some treatment forcefully if he or she does not have mental capacity. So how you are going to check without offending the patient? Just throw a simple question that, okay, do you know why you were brought to the hospital, or do you know what will happen if you do not take the treatment? If the patient says, yes, I had a fall, or I had, if he's in the hospital with a clot, okay, I had a clot and that's why I'm in the hospital. I had a fall in the market like an hour ago. That's why I was brought to the hospital, or whatever. It means that, okay, he knows where he was, what happened to him, where he is right now. So, okay, now he has that mental capacity. Okay. So after checking the mental capacity, you're again doing, and you're going to try once again to convince that patient, okay, and you're going to scare that patient, okay. Scare, how do you scare the patient? Just tell him about the ultimate risk of not taking that treatment, okay. That the ultimate risk is always, it's life threatening. He's in he's hypoglycemic, the glucose levels are low, or if, well, like I said, the patient has some hemorrhage and we have to operate the patient, or there is a clot and we have to give him a warfarin or any heparin, any medication. We are going to tell him, but you know what is going to happen if we don't treat you. Okay, he's saying, no, I don't know. Tell him, okay, you might die if you do not follow the treatment. Scare him, just scare him. Trust me, we humans, none of us wants to die. We don't want to die. And this is not something that you are being a scary doctor. No, you are being an ethical, safe doctor. This is an informed decision he's going to make. You are just informing him that this is going to be the ultimate risk. If you go home right now without treatment, this is how you're going to end. Of course, he doesn't want to die leaving his children or his mother or any one of his relatives or whatever the scenario is. This is just a hypothetical scenario. So scare him. Okay, you know, if you don't take the treatment, it's life threatening and you might die. And then he might stop and think about it, that okay, I don't want to die. No one wants to die. So maybe I can take some help and get treated. Okay. Or if this even doesn't work, there's always sticks and then there is carrots. Okay, always use the sticks first. Okay, the patient doesn't agree to that as well. So you are going to tell him the benefits, that if you stay in the hospital, but if you stay in the hospital, we are going to give you some infusion, we are going to give you glucose, and it will help you. It will help you, and it will make you better. It will make you feel better. You can go home to your kids and everything. Whatever the solution, whatever the treatment you are going to give to that patient, you tell him about the benefit. Okay. No, the patient is still refusing. He's like, no, I'm still so worried and I need to go home. I just cannot. I don't think so. I mean, I still need to go home. Then what you are going to do? Let him go home, because you informed him. You told him about the the consequences, the benefits, everything, but still the patient is refusing. Now what you are going to do is you try to save the patient. The patient doesn't want to save himself, then please save yourself. Be a safe doctor, save yourself, document everything, all this conversation. Tell him, I'll document all this conversation in your notes. Make him sign there's a document in the hospitals in UK, like discharge against medical advice. You'll ask the patient to sign those documents. And you can safety net the patient about, okay, if this episode happens again, please, keep something with you, whatever, according to the station, tell him the safety netting points. Okay. So these are going to be the six steps that you are going to do when the patient is refusing any treatment, anything. It could be a medication, it could be an admission or anything. But mainly, what's the goal of the station? Can anybody please, if you can write it in the chat box? These are the six steps if the patient is refusing. So what's your goal here? Anyone, please write in the chat box, whatever comes in your mind. What do you think is the goal here today? No. Okay, let me see. The main goal here. Okay, got it. Very nice. Check mental capacity. Okay, good. Okay, communication, convince the patient, safety of the patient. Perfect, good. Can you please tell me, there is Shalika, tell the 6 steps again, I join now. I'm just going to, actually this is this is recorded. So I'll just quickly go through all these 6 steps, but you can, watch the video later and go in depth of these steps. Be safe by talking everything is in their autonomy, their mind. Perfect, everything, right, all these things. Okay, just repeating all these 6 steps. 1 minute. First, ask the reassure the patient. It's a reason for everyone. Okay, reassure the patient that, okay, we are going to do, no problem at all. You don't want this, we are not going to give this. Reassure the patient. Don't offend the patient. Reassure him. Gain his trust so that he is able to talk to you. Next, ask him why. Okay, why is your concern? Main concern, eyes. We always talk about eyes. It is the concern in eyes. Okay, now you're going to be the super doctor and you're going to find a solution to that concern, address that concern. Now you find a solution, whatever solution you have. But he still says, okay, no, I don't want that. I just want to go home. You check his mental capacity by simply asking, like, why were you brought to the hospital? To know that he knows where he was, what happened to him, where he is right now, rather than asking, do you know where are you right now? He'd be like, do you think I'm crazy? I know I'm in a hospital. Okay, never offend the patient. Next, it's like consequences, scare him with ultimatum. It's life-threatening. You are going to die if you're not going to do this. He's still refusing. Tell him the benefits. But if you stay here, we are going to save you, or whatever you're going to do for him. And if still he refuses, make him, please document everything, save yourself. He doesn't want to be saved, save yourself, document everything, and then get him signed the document. Okay, so we have a lot of answers. Thank you so much, everyone. Everything is perfect, but okay, the main goal here today of this whole approach is, please, your goal should be not to reach step number 6. If you reach step number 6, it means you fail to convince the patient and you kind of somehow fail the station. So please, your goal is not to reach step number 6. You should be able to convince the patient somewhere between step number 2, 3, anywhere. And to be honest, the patient will be convinced somewhere around maybe step number 2, maybe, step 4, somewhere. And then what you'll do, once you have convinced the patient at step number 2, 4, 5, wherever, he says, okay, fine, okay, doctor, yeah, that makes sense. Yeah, okay, I'll do that. But you, sorry? Okay, so if the patient says, okay, yes, yeah, I get that. So what you're going to do, you are going to simply start now you start the normal station. You have the P1, P2, P3, whatever approach, however you know how to deal. That is a normal station, medical station. You are going to talk to the patient, do the whole data gathering and then examination and management. But you should be able to convince the patient in first 2 minutes. Or if there is a patient who is in the hospital, you are going to discharge him, talk to him, and then suddenly he says, I'm not going to take this medicine. Then quickly go through these 6 steps. But please make sure you don't reach the step 6. You don't reach step 6. You need to convince the patient somewhere between 1 and 2. But that's fine. If you did your part well, you did everything, and the patient is still saying, okay, fine, I know everything, and I still don't want, that's fine. That's okay. Just go with it. Okay, don't worry. Okay, don't stress over it, don't push it. That's it. Be nice, just go through these 6 steps. But trust me, I'm telling you, at some point the patient will agree if you follow all these steps. If you are not offending the patient, okay, you are being nice, you are following the whole approach. But still, if he doesn't say, is that okay, fine, and yeah, okay, fine, that's totally fine. Okay, but again, I'm repeating the same thing. Please don't try not to reach step 6. Please try not to reach step 6. Okay. So next, okay, we have a few questions. I'll try to answer them at the end of the webinar. Okay. Next is, but please keep writing whatever pops in your head, whatever questions you have, just keep writing them. Just keep throwing them in the chat box. Okay. Okay. Section 3 is breaking bad news. Okay. Again. You have a patient and you have the lab results of the patient and you have to tell him whatever, and the patient came for the lab results and he has breast carcinoma maybe, or there's a patient with RTA, there's a CT scan, bleed in the brain. How are you going to, anyone tell me how you're going to start? You can write it in the chat box, or you can volunteer and tell me how you're going to approach the station as well. Anyone? Now you're going to break the bad news. It could be a stroke, it could be a hemorrhage, it could be a cancer, anything. Me, Mariam. Okay, sure. Yeah, Mariam. How you're going to start the station?
Okay. I can start?
Yeah, sure.
Okay. I am Dr. Miriam. Hello. Are you confirm your name?
Yes, doctor. I'm Parva.
Nice to meet you. We are now to discuss some issues regarding to your health. Is that okay for you?
Yes, sure, doctor.
Yes. I am sorry to start with this news. Your investigation is in front of me, and I'm sorry to tell you that your result is not as we are hoping. Um,
Okay, oh my God, what's it, doctor? What is it?
it shows that you have a cancer. I'm sorry to tell you that I know that is it
Oh
must
my goodness.
stressful for you.
What are you saying? Cancer? How did it, when, wow. How could it be? I mean, how can I get cancer, doctor? Why did this happen? Oh my goodness. What are you saying?
I know that I appreciate your concern, and I know that it's something bad for you. But usually the life not came as we are expecting. So the
But
result.
why? I mean, how can I get cancer? Oh my God, this is, I just came here for a, regular checkup. How can I get cancer? Oh my goodness. What are you saying, doctor?
The
Okay,
good thing.
anyways, thank you, Mariam. Thank you. Perfect. Thank you so much. Okay, so now let me give you an approach for breaking bad news, or however you say that. Okay, so what you are going to do first? You have lab, for example, just a scenario that the patient is here for the lab results. Okay, I had an annual checkup, an annual mammography or something, and I have cancer. Okay, now you ask the patient, okay, I have your lab result. You enter the station, hello, how are you? I am this, I have your lab results. Do you want to know about the results? Okay, unfortunately, the results are this is this. Okay, and now I'm suddenly, either the patient will be crying, angry, yelling, I don't know, however he or she will be out of his mind, reacting, doctor, or maybe it's like you're talking to a relative, and I'm the wife, and my husband is in the operation theater, and there is a bleed while doing the operation, and now the patient is angry at you, that, oh my God, what did it happen? Why did it happen? Why is he dying on the operation table? Why is it happening? Okay, and you don't, and you are just, okay, I'm very sorry, I can imagine what you're going through. I can't even imagine what you're going through. I can totally understand. I'm very sorry. This is not IPS. This is not at all IPS. This is not how you're going to break the bad news. Okay, just a minute, there's something. Okay, so perfect. There are so many answers in the we have in the answers in the chat box, and very nice. Very good approach. Most of them are very correct. So what we are going to do is, we are all, there's three steps, basically three parts of breaking bad news. Okay, we always start with data gathering, history taking. Okay, why history taking? Why you are starting the station with data gathering? I just, like we just talked right now, I have so many questions. Why that happened to me? Why, doctor? Why did it happen to me? What did you do? What did I do? And you have no answer. All you're doing is, all you will be doing there is, okay, I'm sorry, I'm very sorry, I'm very sorry. No, this is not going to calm down the patient, but answering his or her questions might calm him down. And how you're going to answer those questions? Only if you have some information, some knowledge, some history. Okay. So I was saying history taking. Yeah. So what you're going to do, we are going to start the station with history taking. First of all, you all know we have 4 marks for history taking examination. We have 4 marks for the management, and then 4 for IPS. But what you do is, in breaking bad news, you only focus on those 4 marks IPS. You're just saying, okay, I'm very sorry. I'm sorry to be the bearer of the bad news. I can totally understand whatever you were saying, whatever phrases you are going to use, that is not going to help you. Okay, not at all. First, you have to focus on the first 4 points, that is history taking. And why history taking? It's not just only for those 4 marks. This is going to help you in the station. How? Why are we taking the history? So first thing, I love this part. Trust me, I love this part of the scenario. And if you do this part correct, trust me, and there are almost, I think, 7-8 breaking bad news stations in PLAB 2, and out of which one is surely going to come in PLAB 2 in your exam. Okay, it's like a cheat code. This one of these 7 or 8 scenarios is going to come in PLAB 2. So you need to be 100%, you should be perfect in breaking the bad news. So how you start with it? You start with data gathering. So first thing in data gathering is what? I don't call it history taking, it's data gathering. Data gathering is not just history taking, it's getting all the information. Examination also comes in data gathering. Anything you get from the patient is data gathering. Any cues, okay? So first, why you are taking the history, you're gathering the data, assess the knowledge. Start with how much do you know? For example, now let's have a scenario that there's a boy with a roadside accident and he was brought to the hospital. We did the CT, there is a hemorrhage. Okay, you are talking to the parents. So first, ask the patients, how much do you know about your son's condition? Rather than starting from, I don't know, from zero, or you need to save your time. Our son had an accident, he was brought to the hospital, CT has been done, and someone we were playing on the road and there was a car that hit my son, the ambulance brought us here, and that's all we know. Now they have taken our son in the theater and we don't know what's happening. Now you know from where to start. Okay, how much knowledge do they have? Now ask them, okay, so how much do you know? Can you tell me about the incident? They'll tell you this happened. Okay, ask about just can I have a little, ask them like anything, that okay, can I have a little chat about your son's health condition, so I'll be able to address your concerns and tell you everything in a better way. Now you're going to ask like okay, has there been any accident in the past? Is there any other medical condition? Is he on any kind of medication? Or just a quick P1, P2, P3, P4 you think that is relative to that scenario. Like for example, if in another scenario the patient is in the operation theater and he started to bleed. Now you have all those bleeding questions you need to ask. Okay, has he has he been in any other surgery before? Is he on any blood thinners? Is there any bleeding disorder? Just take a quick past medical history, just a general, any medical conditions that he's having, any medicines that he is using, any family history. Sometimes family history is very important. There is hemorrhage patient, there is a stroke patient, and there's a very strong history of high blood pressure and stroke or some bleeding disorder. So all those things are important, and you just quickly data together in first 2 to 3 minutes. Okay, so the first thing you're going to do, assess the knowledge. Next is risk factors. How do you know about the risk factors? You know the risk factors after taking the history. When you took the history, now what are the risk factors? A strong family history could be a risk factor. He's on blood thinner could be, I'm talking about different scenarios. Blood thinners could be a risk factor for bleeding. High blood pressure could, a history of high blood pressure could be a risk factor. Then maybe the patient is on any blood thinners, or maybe there has been a history of any such incident before as well. Maybe there was some congenital anomaly, anything that you gather from the data. Now you have the risk factors, and now you will be able to address the concern when you break the news and the patient yells at you that, oh my God, how did this happen? Breast cancer, how did this happen? You asked about any of your relatives have a history of any breast disease or anything like that. Now you'll be able to address the concern when patient is asking, doctor, why did this happen to me? Okay, I know you have a strong family history. Okay, or why did this happen to my husband? Why is he bleeding? Okay, he has a history of this, or he might be using those blood thinners, or so that might be a cause of this. Okay, so this is how important the data gathering is. If you just break the bad news and you don't have answers to those questions, the patient, trust me, is going to have 100 of questions and you need to answer them. And how you're going to answer them? By taking the history. Okay, just simply tell them, I just need to, in order to address your concerns and in order to talk about the condition of the patient, I need to I need to know a little about the patient, or how much do you know about the patient. So just take all that history, gather that history, assess his knowledge, ask the history to know the risk factors. And the third part in data gathering, the most beautiful part, is support system, psychosocial. Ask about support system. Why you're asking about the support system, I'll let you know later on when you're going to break the bad news. So we are on the step 1 right now, okay? And step 1, we have data gathering. Why we did the data gathering, history taking? We assess the patient and knowledge of the patient. That tells us from where to start the scenario, okay? From where to start that station. You don't waste your time on step 1, 2, 3. You start from 4, 5, 6. Okay, the patient has already told you about the 1, 2, and 3 things. Okay, now okay, I have to start from the next step. Or the patient knows nothing. You start from 0. Okay, so when did this happen? Why does this happen? Has it happened in the past? Any other medical conditions, any other medicine he's taking, any family history, whatever you questions that are related to the scenario or that particular condition, you ask those questions. Okay, those are, you gather the risk factors. And now you ask about the support system. Is there anyone else here in the hospital with you? Trust me, most beautiful question. Is there anyone else here in the hospital with you? He says, yeah, I have my husband with me. Or he says, no, I don't have anyone. Okay, who do you live with? Okay, I have my kids at home, or my wife at home, or anything, whatever the support system he or she has. Maybe he doesn't have a support system, but in most cases, the patient will tell you a support system, that I have this XYZ in the hospital, or XYZ at home, XYZ in some other city, whatever support system he tells you. Now this is data gathering. You are done with taking history. You did these 3 steps. Now comes the breaking bad news. Now again, in breaking bad news, we further divide the breaking bad news into 3 steps. Okay. The first step is going to be first warning shot. What is first warning shot? Now you are not going to straight away tell him what's happening. Just you first prepare the patient. Okay. So I have your results here, and unfortunately, I don't have good news. Or your son is in the theater right now, and I don't have good news for you. Take a pause. Sometimes it's not just what you are saying; it's sometimes what you're doing. Take a pause. Take lots of pauses in breaking bad news. Obviously, if you're talking to me and something bad happened, someone died, something happened, you're telling me, you'll be telling me very calmly, very slowly, taking a lot of pauses. Do the same thing with the patient. In the station, first warning shot will be just telling him, okay, I'm going to tell you something bad, something unexpected, unfortunately, something bad has happened. Okay. Second warning shot. Then comes the second warning shot. Now comes the support system. Do you want me to call your husband, who is maybe sitting in the other room? Do you want to call your kids or whatever? Do you want to call me XYZ to be here with you? Whoever the support system he already told you in data gathering, tell him about while I tell you about the results. Okay, he says yes, or he says no, whatever he says. Now you're going to, third step is break the news. And what the news is, it is basically the provision diagnosis. It's the diagnosis. Now, how do you tell the provision diagnosis to the patient? Again, now it's like a flow chart kind of thing. Okay, the flow chart is, first of all, we have 3 steps in such a station. The first station is, the first step is data gathering. Data gathering was further divided into, there were 3 things. You assess the knowledge, you take the history, which are basically the risk factors. You ask about the support systems. Second, breaking bad news. Again, you divide it into further 3 parts. First warning shot, prepare the patient. Okay, something bad is coming. Do you want anyone to be here with you today? Or not anyone, you already know the support system. It seems that, okay, you care for the patient. You actually care for the patient. You're not just acting, you care for the patient. You already know, you already asked about the support system, and now you are, okay, can I bring the support system? Do you want me to bring that support here to be with you today? Okay, then the news. Yeah, okay, unfortunately, we did the CT scan, we did the mammogram, we did this, and unfortunately, the result is not what we expected it to be. Now comes the provision diagnosis. How you tell the provision diagnosis? You always tell, okay, first tell him, okay, it's a stroke, it's a hemorrhage, it's a ductal carcinoma in situ, okay? And then you ask the patient, okay, it's stroke. Do you know what is stroke? Assesses knowledge. This is going to save you time. If you assess the knowledge and he says, yeah, doctor, I know about it. Okay, fine. You don't have to explain it. It saves you time. If he's saying, no, doctor, what is it? Maybe he already knows. I'm telling you, patient is going to help you a lot. He is going to save you time. He's going to help you pass the station. So assess his knowledge. Ask him, okay, so it's stroke. Do you know what it is? Okay, no. You want me to explain what it is? Yes. Now tell him what a stroke is. it's the no, stroke is the provisional diagnosis. So stroke is what? It's a condition of the brain. Okay, so in provisional diagnosis, there are two steps. You always tell first, it's a condition of what? Ductal carcinoma in situ is a condition of breast. Stroke, hemorrhage, it's a condition in the brain. Okay, and then what happened in layman language, simple language, there is bleeding. It's a condition in the brain, a vessel ruptured, there is bleeding. Okay, or in the condition in the brain, there is a clot and there is a blockage of one of the vessels in your brain. Okay, or it's a condition of the breast where there are some unusual. I personally prefer, don't use the word abnormal. Abnormal is very alarming. Just say unusual, unusual. Anything, whenever you're like, do you have any abnormal discharge? Rather than say, do you have any unusual discharge? Any unusual color? Anything unusual that you noticed? You know, always, I think it's better to use unusual. Okay. So tell him it's a condition of the breast and there is some unusual cells in the tissue of your breast, or whatever other scenario you have, and you have to now you explain the news. This is the news, this is the diagnosis, and during all these things, take a lot of pauses. Okay, let the patient absorb the news. Okay, tell him, and then you're like, see how the patient is reacting. Don't just rush into, okay, it's stroke. Do you know what is stroke? Do you want me to explain the stroke? Okay, stroke is this. No, just tell him first, break the news and wait. Let's see what the patient says. Maybe he's just sad, or maybe he has a lot of questions, or maybe he doesn't have any questions at all. He's not even interested to know what it is, how it is. Follow the patient. Okay. And then the step 3. Now that was a flow chart. Now we are moving back to step 3. Step 3 is the management. Now we have the management, the treatment options, the solution, whatever you were doing to the patient, you were operating the patient, you were, if it's a breast cancer, what are the treatment options? It's going to be surgery, radiation, whatever, chemo, whatever, according to the station, whatever your treatment is, go with the treatment. I am not discussing any particular station here. I will never be discussing any particular script of any particular station. I'll always be giving you an approach, because when I tell you, okay, this is a patient comes with this, you ask this is the treatment. No, you're always scripted. No matter how hard you try, once you see it, once you hear it, if you are not able to unsee it or unhear it, that will always be in your head. Okay, I have to ask these questions. No, it's just a simple approach, and you can apply this approach for breaking bad news in any station in the world. Anything comes, anything, PLAB, GMC throws anything in at you, you'll be able to handle the patient, because you took a history. In the history, the patient will, when you start taking the history, the patient will tell you, patient or relative will tell you whatever is related to that station. That will help you in breaking the bad news, because after breaking the bad news, when you give that pause, now patient maybe has a lot of questions. Why did this happen? Okay, there is a family history, or the patient was using this medication, there was a risk factor associated with this operation, whatever risk factors you gathered from the history taking. And then comes the management. Now, whatever treatment options, either the patient is already in the operation theater, you are treating the patient, or whatever treatment you are going to give to the patient, you will tell about the management. Now, at the end, always be the safe doctor. At the end is one small line. That is something I would like you to tell the patient, that, okay, again, please remember my name. My name is Dr. Farwa Aslam. I am sure you must have a lot of questions. Please come to me, ask me whatever pops up in your head. Please come to me, tell me, ask me. You can come to me at any time. Just please, always at the end of the breaking bad news, tell him that I'm here for you. I am here for you, available for you anytime, anywhere. You can, obviously the patient is upset. Maybe in those 8 minutes, he's just crying, he's absorbing the news. But like I said, consider that the patient is just one of your regular patients. It's not just those 8 minutes. You are there for the patient. Just tell him, I'm here for you. Remember my name. You can, just find me and ask me whatever question that pops up in your head. Okay. So again, we have data gathering. We have the news, 2 warning shots, 1, 2. In second, ask about the support, then give the news, provisional diagnosis, wait for the patient, give so many pauses, see whatever questions the patient has, try to answer them. How? Through the data gathering. And then management is going to be very simple in 1 or 2 minutes. Sometimes it is, maybe the patient is going to die and you are going to put him on palliative care. Then of course, again, ask the patient, do you want to know about palliative care? Do you know what is palliative care? No, if trust me, if you're short of time, the patient will tell you, okay, no, I know what it is. Thank you so much, doctor. You'll be like, okay, wow, everything is done. Sometimes the patient even knows you have time and he'll be like, no, doctor, what is palliative care? So always ask the patient, what do you want me to do? How you want me to take the station? He will help you, he or she will help you, okay? And then again, at the end, tell him, find me, ask me whatever questions you have, and then thank you. Okay, so that was our. Okay, so now we have a lot of questions. Let me see. Before answering those questions, everything is clear? Do you want me to repeat anything? Is everything clear? Just throw some yes, please, in the chat box. I mean, did it help? Okay, sure. Let me just first go through. Can you do it first? Okay. Just let me answer the questions first, I think. So I'll repeat everything at the end, but let me, just first answer the questions so that if anyone, because this is all for the webinar today, if anyone wants to leave after this, they can. Let me just see the questions. Okay, this the first question is about power of attorney. It's actually a totally different approach. We have a different. I have a different approach for this as well. I'll talk in the next webinar about talking to a relative. How do you talk to a relative about all this power of attorney and what the relative wants to do? If everything, this is a very good question, but I'm going to talk in the next webinar because again, it's a very detailed. There will be a detailed approach how you're going to tackle such a relative. Okay, talking to relative. I'm going to talk about this on next webinar. Next question. Okay, if the patient said that he knows he will die, okay, fine, you have done your part. He's still not agreeing. Like I said, okay, fine, that's it. You did your part. You counsel the patient. He still wants to go. Okay, fine. You are not going to force the patient. He has the mental capacity. He wants to go home. You can never force your treatment, your anything on the patient. Never. But that's an informed decision. You inform the patient first. That's we have step number 4 and 5 for that. You are going to inform the patient about the benefits, about the consequences. He still says, no, okay, fine. No, that's it, fine. That was a question from Shalika. Then we have... okay, and now Dr. Hajar Hussain. Okay, like I said, assess the knowledge of the patient. That's all. You need to take a brief history, assess the knowledge first. The patient will, relative, patient, whoever is in the cubicle with you, he will lead you, okay, and you will know what to ask. And always take a quick history according to the scenario. If it's a hemorrhage, you need to ask about those bleeding questions. There are always some not red flags, or there are some, I would say, the star questions. They are star questions for every scenario, and you always have to ask about those star questions. Okay, so always in each scenario you have those star questions. Ask about those first. Okay, then we have I already replied to the question. Okay, there's a quick question. Is it a must to say one of the junior doctors at, or is it fine to say I'm one of the doctor here? Okay, interesting thing, when you enter the station and you're like, okay, I am Dr. Parvaz, so please confirm your name and age. I personally don't like that. It's very robotic. Just, again, you cannot see me right now, but what if I enter the station and I'm like, whose question was this one? It's Muhammad Al-Maki. What if I say, hello, good morning, Muhammad Al-Maki. And I note the head. I look into his eyes and I'm like, okay, Muhammad Al-Magi. If he is Muhammad Al-Magi, he would be like, okay, yes, doctor. If he's not, he'll be like, what are you saying? Who is Muhammad Al-Magi? Simple as that. Rather than being like, please, can you tell me your name and age? That sounds little rude. I don't know, little cold to me. So always enter the station and like, okay, hello, I'm Dr. Hello, whatever the name is. Hello, Anthony. Hello, Amika. And note your head. If it's Amika, it's Amika. If it's not, it's not. Okay. And then tell. Okay. And it's fine. Just tell them, I'm a doctor here in this department. My name is this, whatever you have it. If the patient is yes, if the patient is silent, give him time. Just take a pause. Let him take a pause as well. Take a pause as well. Don't rush in. Don't rush the patient. Okay. Let him absorb. The Breaking Bad news is all about it. Obviously, if someone is telling me I have cancer, I will be in a shock. I might not be able to say anything for even if you keep asking me, okay, do you have any questions? I'll be totally blank. I won't have any questions at this moment. Okay, that's fine. Give him 30 seconds, 40 seconds, even if it takes, I don't know, 1 minute, that's fine. And then, okay, he'll automatically ask you the questions, or then you can say, okay, do you have any questions for me? Okay, and then you can address those concerns. This question, yes, if they have the power of attorney and obviously whatever decision they make, you are going to go with that decision. But again, while I was saying that before in the next webinar, you always ask, okay, why you want to do this. You try to address that concern. So you first ask why you want to do this, or okay, again, like it's it's basically kind of a refusal station. Okay, the patient relative is saying, no, I have the power of attorney. I don't want this treatment. Again, you go with the refusal approach. You start with, okay, that's fine. You are the power attorney. You have the right to do whatever you think is okay for the patient, but can you tell me why? Okay, then whatever the concern is, address that concern. Then you go with, okay, do you know? I mean, if you take him off the treatment, this is going to happen, or maybe we can keep him here, or tell him a little bit here and there. And then if he still says, no, I want to take the patient, no, obviously you cannot do anything about it. Okay, but again, you follow these steps. There was another question about we never break the confidentiality, never, never and never, no matter what. For example, if there is, you can always talk like this. For example, there's a mother who came who is concerned about her daughter, that she's taking contraceptive pills, and you are at a GP clinic, okay, and the whole family is coming to you, and she came to know that her daughter is taking contraceptive pills. She came to the clinic. Who gave her the contraceptive pills? How did you give her the contraceptive pills? And now she's bashing at you. You are provoking her to have sex, or whatever questions. You are never going to break the confidentiality if her daughter have the mental capacity, is above age. You are not going to ever breach the confidentiality. You can always talk like, okay, obviously you have to address the concerns of the mother, so you can talk, okay, fine, whatever, Miss Rose, I can tell you, if I cannot tell you about your daughter, I cannot talk about her, but I can tell you if any girl who is of the same age as your daughter and comes to us with this particular thing, how we are going to help her out, or what we are going to do about her, that might calm you down, or that might help you with your concerns. So as a third person, you can talk about, okay, this is what we will be doing to such patient, but never particularly talk about that patient. Never, under no circumstances, you are going to break the confidentiality. Yes, for mercy killing, yes. If they have the power of attorney, they are the decision makers. If the patient himself is not a it's not a, to be honest, it's not a real life scenario, but Yeah, not happened to me, but yeah, I know this for a fact. I've seen it somewhere that if the patient himself, even if the patient himself wants to don't wants to take the treatment and wants to kill himself, and he is totally mentally stable and he wants to do it, yes, you cannot do anything about it. You can only tell him about, you can inform him, help him make an informed decision, but at the end of the day, the either decision is of the patient, or if yeah, he is not conscious and there is a power of attorney, then yes, you do that. You can, I know you don't want to do that, but you have to do that. You are ethically bound to do that because the patient wants that. Okay, there's a question about it goes into depression again about that, like I said, it's just actually a webinar. If we go into detail of each and every breaking bad scenario, sometimes you ask, okay, if the patient, there's a boy, your son, he was in a roadside accident, so you ask, okay, do you have was there any other kid who saw the accident? Or you ask, do you have any other kids? Maybe he is the only kid. If he is the only kid and he is about to die, obviously they are going to go in depression. Or if they have another kid and who saw this whole traumatic experience, who had who saw the whole accident happening, bleeding, everything, and the kid is very young, obviously that is also traumatic to that kid as well. So yes, you are going to offer help, psychological help, emotional help at the end, that okay, we can provide you, your family, your husband, your son, anyone, we can help you with some psychological help to cope up with the situation as well. Yes, you will at the end address that concern as well. Okay. Yes, exactly. Thank you so much, Hina. Javed is right, very right. Okay, perfect. So I think that's all for today. I hope this was helpful. I hope I didn't waste your an hour or something around an hour. And I hope to see you all again in my next webinar with some more interesting topics. Thank you so much for today. Have a good day, everyone. Bye.